to introduce our speaker, Dr. Katherine Chinyere Mobisson, who is a psychiatrist of many years of experience in both adult, child, and adolescent psychiatry. She owns the Practice Biological Psychiatric Center at Roseville, Michigan, USA. She is a former director of child and adolescent psychiatry at the League Treatment Center, Brooklyn, New York. She has years of experience under her belt, vastly educated, and we are looking forward to having her speak today. As you can see on the screen, you will see how educated she is. I'm not going to go into all her degrees and her work experience, but she has 15 years post-fellowship education here. And so it was with great pleasure and warm affection that we invite Dr. Katherine Chinyere Mobisson to proceed with the topic for the day. So we're going to stop sharing our screen. So Dr. Katherine, you can share your own screen.
Are you able to see my screen?
Not yet.
Okay.
It's coming up.
Okay. Can you see it?
Yes, please. We can see it.
Okay. All right. So good afternoon, everyone. It's still morning for me here, but I know it's evening time for most of you, depending on where you are. So today we're going to talk about postpartum depression. And the agenda is to talk about briefly what it is, why do we even care about it, how common is it, right? And how to screen for it. We're going to talk less about diagnosis and more about just a screening, okay? And then we'll talk about treatment briefly and how do you cope with it. And then finally, we're going to look at what family and loved ones can do to support a woman who is suffering from postpartum depression, and then taking in mind some cultural factors. Now, first and foremost, what is it? Why should we care? Now, everyone knows that typically the birth of a newborn is supposed to bring joy, happiness, a sense of pride, a sense of fulfillment. That's the goal, that's the hope. However, there's so many changes going on within a woman's body and outside of her body. Everything from dealing with the experience of being pregnant, complications related to pregnancy. Can you hear me? Oh, I heard something. Okay. The complications, right, that one can experience during pregnancy. And again, her body is going through changes right after delivery, right, which could be very difficult. Sometimes we have smooth, straightforward vaginal deliveries. Sometimes there is trauma. Sometimes we have to go through a cesarean section, which can be emergent. So that alone can be a stressor. And then afterwards, we're dealing with hormone shifts in the context of getting used to life with a new child, okay? It may be your first child, you could have several children, but there are a lot of changes. Families can be exposed to increased financial stress. There are dynamic changes within the family. All of these, even though, again, it's should bring a sense of joy, can be very stressful. And in that order, it is important to talk about postpartum depression, which is mostly what I'm going to focus on, but also anxiety and other mental, psychological disorders that come up. Now, very briefly, we're going to talk about baby blues. Okay, another term is maternity blues. Okay, and there was a slide referring to that. This is very common, and it's not postpartum depression. It's not the same. They share some symptoms, but it's not the same thing. For baby blues, and I have a slide coming up, But for baby blues, it's basically, a few days after birth, you might feel emotional, you might feel tired. 1 minute you're happy, another minute you're sad. And that's pretty much it. It lasts a few days, then you start feeling okay. Postpartum depression is more serious, okay? And just by definition, it's depression that relates to pregnancy and occurs within a very specific time after a woman is no longer pregnant. Just to avoid confusion, postpartum depression is also called postnatal depression, okay? And there's something else called perinatal depression. That includes depression that occurs before you have the baby and afterwards, after pregnancy, okay? So it's it's around. So everything's around the time of giving birth. Now, it is important to know what that is because there is also something called antenatal depression. And that is depression that a woman experiences prior to giving birth while she's pregnant. Okay, there are many women who go through an episode of depression, whether or not it's actually diagnosed, and then they recover. Okay, again, important to note because 50% of women who experience antenatal depression go on to experience postnatal or postpartum depression. All right, and another point is that what we're calling postpartum depression may start developing symptoms before birth. Now, on the bottom of this slide, they've been doing a lot of research to figure out who is more at risk for experiencing both. If you look, it makes sense, right? If you have food insecurity, if you and your boyfriend or your husband are not getting along, there is physical abuse, you're going to be at risk, okay? If there is tension, if there is drinking, it's going to exacerbate things. This is the section down here is actually from some research that was done in South Africa. If anyone wants the citation, I can send it to get more details. Now, just again, as I said, there's a difference between these two, and one of the slides points to this, okay? Baby blues begins 2 to 3 days after birth, after delivery, okay? It lasts less than 10 days. Peripartum depression lasts 2 weeks at least. It has to be 2 or more weeks. And typically, it's commonly seen within the first month, but it can occur anytime in the first year of postpartum. Also, someone with the depression is having more trouble functioning than someone with the blues, okay? And then the final piece is that if there's any suicidal ideation, if you're thinking of harming yourself or killing yourself, it's not blues. Doesn't matter what, you need to pay attention to it, okay? Even if it's day 2, okay? Now, in terms of the duration, I mentioned that it can last up to a year. There is some controversy. I'm not going to get into it right now, but for us who are diagnosing, there are different criteria that we use. There's something called the DSM-4. There's something called the ICD-10. DSM, which is used in the United States, says you have to have symptoms occurring before 1 month after birth. ICD says 6 weeks, okay? But many other people believe that the criteria should be extended to 1 year, okay? So don't ignore it if a woman comes to you 3 months after birth complaining of these symptoms, and it should still be screened for. Now, this is very important, and there was a question there that was highlighting this, okay? So postpartum depression can also occur in women who have had a miscarriage or an abortion. And I saw on the slide that no one clicked on the woman that had the abortion, okay? So it doesn't matter what the reason for not being pregnant is, okay? They can still, even if the person wanted the abortion, okay? So keep that in mind. And this is especially particular for screeners who are not in the obstetric GYN practice, okay? If you're a primary care family doctor, you have someone, a 20-year-old who said she had an abortion 3 weeks ago, you might want to do some brief screening, okay? Now, why do we care about this? Okay, you can see the slides, right? First and foremost, diminished mother and child bonding. This can affect the child's growth and development, their thinking, their emotional development. If you think about it, if someone is struggling with postpartum depression, they may have trouble feeding the child, which can lead to undernourishment, which again can affect them in the long term. And then ultimately, our biggest, the most feared outcome is infanticide and suicide, okay? And it happens more than we would like. Another impact, which makes sense, is, husband, boyfriend, father. If your wife is not happy, she's sad, it's going to impact you and how you feel. And there's going to be an increased risk of marital discord and divorce, all right? And an increase in family violence, domestic violence. Let's go more specifically over the symptoms. I'm not going to go through each one of them. I'm going to highlight a few of them, okay? First slide, first section, okay. Some women manifest as being sad, empty, just not moving, talking slowly. There are others who are very moody. They get agitated, they get irritable. Many times when you talk to them, they say, I could have beat up my husband, or I could have thrown the baby. Okay. They usually will not tell anybody this. Okay. But when, myself, because I'm a psychiatrist, this is the kind of feedback I get. So it's not just, oh, I'm sad, I'm in the bed. Okay. And there can be rage. So that was something that I put on one of those slides, because there is not a huge recognition, and this is all over the world, for phenomena such as postpartum rage, anxiety, and psychosis. Okay. So it's not just depression. So you should keep that in mind. So the others are self-explanatory. You're not interested in things. You may not be eating, or you're eating too much. Okay. You need to eat more, because especially if you're breastfeeding, but this is sort of emotional overeating. Lack of interest in the baby, not feeling connected. Okay. So there was a slide referring to that. A lot of women feel very, very ashamed of this. Okay. So many times will not share this with their husbands, sometimes not their provider. You have to ask specifically, and it's very difficult for them to say this. Now, another phenomena is somatic or physical phenomena. And I'm bringing this up because not every culture, and this is, again, throughout the world, not everyone is going to say, oh, I'm sad. You might hear about complaints about pain with no identifiable cause, headaches, stomach aches, all right? Then there's fear of harming or killing the baby. Now, this is part of anxiety. Sometimes there's this heightened nervousness about anything happening to the baby, okay, which can impact sleep. I see this in women, they have night terrors, okay, and I have had patients who jump up in the middle of the night, they check the baby, they keep going back and forth, all right, and that is some of the anxiety I'm referring to. Suicidal or homicidal thoughts, okay, I think that is self-explanatory. Now, the next one, purposeless activity. So again, as you see, there can be restlessness, there can be pacing, just not able to sit down, not able to think and make a clear decision. On the other end, I referred to it a little bit, it can be just slow, just general slowness, hard to speak, hard to put thoughts together. And very important is the guilt and feeling worthlessness. And this is definitely amplified in postpartum depression, because very commonly the mother feels ashamed that she's even feeling any of these things, and very guilty, which makes everything worse. Now, risk factors and enablers, okay? Again, I won't go through all of them, but they are self-explanatory. Definitely, if you have any history of a mental health disorder from the past, you're going to be at risk. Depression, whether it was during a pregnancy or just in between pregnancies, or if you never were pregnant, you're at risk. Okay, post-traumatic stress disorder, or actual trauma. You may never have known if you had post-traumatic stress, just history of trauma, being in a severe car accident, being a victim of rape, domestic abuse, or other situations. Financial strain, that's explanatory. New or teenage mothers. Okay, that was on one of the slides, and I also see that it seems like that one was disregarded. New mothers have a higher risk for postpartum depression, just off the bat. And then teenage mothers do even more. Okay, so if you have, and that makes sense, if you have a 16-year-old, I mean, that's a lot of stress. They don't always have the maturity to handle pregnancy, handle a child. They probably had to leave school. People are probably not happy with them. I'm sure the whoever got her pregnant is not necessarily planning to marry her. Okay, so those are all stressors that increase risk. Now, obstetric and pediatric factors include, obstetric would be, of course, the pregnancy itself, right? Complications during the pregnancy, were they there or not? Obviously, anything like that is going to create stress, increase the likelihood. Mode of delivery as well, all right? There is some data that shows that women who go through delivery through vacuum extraction have a higher risk of postpartum depression and emergency cesarean section, okay? And there was the one question talking about the emergency C-section where the woman lost blood and required quite a bit of care, okay? So those folks are at higher risk as well. There are cultural factors as well, and we'll talk a little bit about them towards the end. Some other obstetric factors include, and after delivery, and I won't get into them too much now, but underactive thyroid, okay? So hypothyroidism can look a lot like depression. In fact, one of the symptoms can be depression, but there are other symptoms that a professional, healthcare professional can screen for to determine if this is really an issue with their thyroid. Other pediatric factors include if you have a child who is born with deformity or an illness or requires extra care, that can increase your risk for postpartum depression. And then, of course, another one which makes sense is if there are difficulties lactating and breastfeeding. Again, this is global a source of shame for women when they are struggling with it. And that is a risk factor for depression. I've seen a lot of that in my practice. Now, surprise, surprise, husbands and fathers and boyfriends can get postpartum depression too, okay? So about 10% of fathers become depressed a bit before or after their baby is born, okay? Again, it makes sense. It's stressful for them too. Sorry, I actually moved. Uh-oh. All right, I'm gonna hold. I'm not gonna move any further with the slides, but it makes sense that they would have postpartum depression because it's stressful for them. They aren't getting the same kind of attention from their significant other. They are also experiencing sleep troubles and they're not getting sex. Okay, so there's a lot of changes for them too. Now, for men, you tend to see a high rate of postpartum depression 3 to 6 months after birth, okay? Which is why you saw the one slide that I had. The guy, I think it was like the child was about 3 months. All right, now I wanna go back to my slide, but I may have some difficulty. Okay, I'm not gonna, it's, you know what, it's clicking forward.
It's moving. We're on global implications now.
Yeah, but it's not.
Backwards?
Yeah, and for some reason it's not allowing me to.
Maybe you can stop sharing and start sharing.
Yeah, that's what
again.
I'm going to do. Okay, hold on one second. I'm going to try to get back.
Okay. So while Dr. Katherine is trying to get her slides sorted, please feel free to chat in to the participants. Please feel free to chat in any questions you might have. Wow. So it's still showing. You haven't stopped sharing.
Yeah, stop share here.
Okay, great.
All right, give me a second and then I'm going to get back.
No problem at all.
Okay, but how can I get?
So you were, go down.
The fathers.
So welcome to everybody who is here. I saw some of our our subject matter experts sneak in during the presentation. Welcome, Dr. Museni. Welcome, Dr. Modupe to the call.
After this.
Please, if you're just joining us, please introduce yourself in the chat and keep your questions coming. Dr. Katherine and our group of subject matter experts are eager to answer your questions.
Share screen.
And thank you, Prince. I see some comments. Prince is saying he's enjoying the lecture so far. That's really exciting to hear. I see a lot of health facilities. Lube PhD, I saw two wonderful babies pop up on your video. That's exciting to see.
You have to share your screen first.
I can do it. Can I just? Oh. Okay. Share screen.
Those of us on the call who have had babies, is any of this resonating? Can you remember feeling this way? If yes, please chat in your experience as well.
Share now.
We're looking forward to both comments and questions. Wonderful. The slides are coming back up.
Can you see it?
Yes, we're good to go.
Okay, sorry for the interruption there. Okay, so I was talking about postpartum depression in fathers, and I'm going to go through some of the symptoms, which some of them are similar to those that women experience. So anger, irritability, or aggression, okay? Loss of interest in work or favorite activities. What is commonly seen is the irritability, okay? And classically, you may see husband, father coming home from work, more isolative, not engaging as much. There can be increased alcohol use. And that you saw the one slide that I had referring to that. Or, you know, they may be coming home later, okay? So it's very, very common, and it's important to take note of. Now, let's get into the prevalence of postpartum depression, all right? Again, throughout the world, we're still collecting data. I would say over the past maybe 10, 15 years, there's been increased awareness of postpartum depression. Now, it's definitely more frequent than we thought. Unfortunately, in Africa and other developing continents with developing countries, I'm putting that in quotes, there is particularly problematic issues with collecting the data. However, like I said, we're getting more information about it. Now, throughout the world, one of the problems is that women are not screened on a regular basis for postpartum depression. And they're also not necessarily screened in the antenatal visits. And again, this is the United States. We have a big problem with it, and more awareness needs to be paid to it. Now, very generally, the world global prevalence is thought to be 15 to 25%, maybe a little bit more now. And as you can see from this slide, the data, you know, the numbers are changing, all right? Now, I had the one question talking about whether this is an issue in non-Westernized countries, and it is. They now realize that actually we in Africa, in Nigeria, may actually have more undiagnosed postpartum depression than in the Westernized countries. Now, again, we don't have all the data, but I'm just going to show you this slide. This is about depression, not postpartum depression. If you look where it says African region, that's pretty high. Let's go to the other end for world. So without even analyzing the data, you can see just the information on general depression. It tells us it is a big issue in Africa. Now let's get into screening. All right, this is again a problem throughout the world, And it has to be done in antenatal, that is prenatal visits, and postnatal visits, and by other practitioners. Okay, so whether you, like I said, if you are a family physician, if you're a dermatologist, if you are an endocrinologist, and again, if your patient mentions that she had a miscarriage, you should pay attention because she's at risk. Now, in terms of screening, and again, I'm not going to go deeply into this because we're not getting into how, for example, I would diagnose it, all right? But generally speaking, you want to make sure you include, as a healthcare provider, questions about their mental health history. Is there a history of depression in the past? Is there bipolar disorder in the past? And there are some questionnaires that can help with the screening. You can also ask about suicide, okay? That's a very quick question. I think in a questionnaire, it's useful many times. If you ask them directly, depending on your relationship with them, they're not going to tell you. Now, a very, very important screening scale is the one that's in the third part of this. It's the Edinburgh Depression Postpartum Scale. This scale is used throughout the world. It is easy to administer. It doesn't require much training to administer. It's available online. You can download it, and it's very easy to use. And it has been a very good predictor of women who are at risk for postpartum depression. It doesn't diagnose them, okay? But depending on their scoring, you then can ask some more questions and make appropriate referrals. Now, this is a little bit more about it. I'm going to show you a sample of the scale. This is the scale. We're not going to go through all of the questions, okay? But you can see two of them here, all right? On the back of the scale is the scoring. So again, you really don't need training to administer this scale. Now, this is another scale that I personally like better, but again, the other one is more commonly used. This one I think has more questions about anxiety, which again is not focused on enough. Now, let's get into treatment and coping mechanisms, all right? And actually, before I get into it, I want to mention one thing about those scales. So those scales they're not very culturally sensitive, okay? So if you're going to use them, I would advise you to supplement them depending on where you are working, okay? Because there are some people, some women who manifest their symptoms in the form of pain, okay? So, or headaches or stomach aches or things like that. So keep that in mind, because otherwise you could miss some people that need referrals. So into treatment and coping mechanisms. Now, first and foremost, you know, as an individual, you need to know, you have to be able to recognize that this is a problem. I think many women, again, due to guilt and shame, just have trouble admitting it to themselves, okay? So you recognize you have the problem. This is if you, again, sometimes we don't know ourselves. Sometimes someone else has to tell us, okay? But acknowledging it, okay? And then realizing it's not your fault. You did not cause it. It's actually a medical condition. You did not create this. And going forward from that. And again, you know, this is more for mild, moderate depression. There's some people that can't function and they're not even at a point of recognizing. They need help and immediate medical treatment. Now, the first and foremost, I'm just going to start with the most important and safest way to get help is if you realize you have a problem and you have access to a healthcare provider, then talk to them about it so they can do the screening and determine whether you need, what kind of treatment you need and how severe it is. That said, mild and moderate cases, some moderate cases don't require any, you know, intervention by a therapist or a psychiatrist or really a doctor, all right? Now, a way to distinguish them is, again, anyone with the suicidal thoughts needs to be referred to a professional. But if you're having some appetite issues, some sleep issues, but you're generally functioning, you may not have to see a provider. And again, if you cannot engage in any coping strategies, you have to admit it to yourself and try to get to a healthcare provider. Now, in terms of coping mechanisms and treatments, they range from, again, strategies all the way to medication, to hospitalization, to ECT. But let's start with mild to moderate, okay? Now, for social supports and self-care, you may want to just be by yourself and not talk to anyone, but it's important to let people you trust know how you're feeling. And also take time for yourself, okay? So even though we don't want you to isolate, if you're feeling overwhelmed with the baby, ideally you want to let your husband know, a family member know that you need some time. Even if it's 20 minutes to go and read, go for a walk, talk to someone on the phone without holding the baby. It's also, you want to try to understand that you may not be able to accomplish everything that you normally are able to do, whether it's in the household, whether it's cooking, cleaning, going to the shop or to the market. You cannot do all of these things, okay? And it's important to understand that that's okay, because again, that guilt and shame can make the depression worse. Sleep is extremely important, okay? Because if you saw the risk factors, sleep issues, insomnia increase the risk for depression. So it's important to make sure you get adequate sleep. Even if, if your husband is working through the week, try to catch up on the weekend, okay? Take naps when you can. For breastfeeding, try to feel comfortable with expressing breast milk and allowing others to bottle feed, other trusted caregivers to bottle feed so you can take a nap. In terms of anxiety, a lot of women, again, struggle with these intrusive thoughts about what they need to do, what they haven't done. Sometimes it helps to get it out of your mind on paper, right, in a list. Journaling, either writing down how you feel is helpful. Sometimes writing down gratitudes, blessings can be beneficial. All right. And the other bit is also to just acknowledge how you're feeling. So if you want to cry, it's okay to cry. If you're feeling rage and anger, you can acknowledge it to yourself. Okay. The problem is when you start keeping up everything, we start to get into excessive internalization, which makes depression worse, or acting out, right? So if we're feeling those rage emotions and we bottle it up, then we can get into aggression, okay, and violence. Now, these are other just general lifestyle changes, okay? Exercising when you can, okay? Again, if you're healing from a cesarean or something else, you may not be able to, but keeping those things in mind. Dietary changes can make a difference. Again, I mentioned the realistic expectations. Meditation can reduce stress, all right? So, and that could simply be deep, they call it diaphragmatic breathing, okay? So again, say you're feeling really tense, deep inhalation, slow release, okay? And there are many articles online. There's some apps actually that teach you how to do it if anyone is interested in. Now, also asking for the help when you need it. I mean, it would be nice if people knew you needed help, but sometimes that doesn't happen, okay? Now, very briefly with foods, these foods may be helpful in lowering your risk of developing symptoms, okay? So foods rich in omega-3 fatty acids, and that includes, oily fish, such as mackerel, Titus fish, croaker, sardines. Now, not every fish is available to us, but these are some of them, okay? Caviar is not on the list, but that also is high in omega-3 fatty acids. So other sources are soybeans. I mean, the reality is, and I was doing some reading about this, in Nigeria, there is not an abundance of foods rich in omega-3s for varying reasons, including the fishing industry, but that's a whole nother discussion. But interestingly, free-range eggs have a high amount of omega-3 fatty acids. So when I say free-range, I don't mean the eggs from like the huge farms with chickens that have been fed with, wheat and bran. These are regular chickens that are in the backyard eating insects because they get the omega-3s from insects. So basically, eggs, local eggs are actually high in omega-3s. Now, this is very straightforward. I think anyone who's actually able to log on today obviously has some digital access. You definitely want to make sure you're communicating with friends. There are online postpartum groups that are free. Now I'm getting into some of the other treatments, therapy, which again, we may not all have access to, but it can be very helpful. The most short-term, easy to learn and be trained in therapy for postpartum depression is interpersonal therapy. Okay, it's a very manualized treatment. They're available online. You can actually download manuals, and healthcare providers can be trained to do this in the community. Now, medication is also treatment. This is actually the large part of what I do, okay? So I usually see people with more severe symptoms. Many of the medications that are used for regular depression are used for postpartum depression. And in terms of breastfeeding, they're safe for breastfeeding. Less than 1% is secreted in breast milk, all right? Because a lot of people are afraid of that. For the commonly prescribed drugs, it's not a huge concern. For depression, there are some anxiety medications which should not be used in conjunction with breastfeeding. Ultimately, in severe cases, we're talking about hospitalization, especially if there's a safety factor. Now, let's get into cultural practices very briefly. Throughout the world, and I'm saying non-Westernized countries because unfortunately, the family unit is shrinking. It's happening everywhere, but there are still some cultural traditions that are still practiced with the goal of making sure that the mom is safe, that she's recovering, that she's cared for, that she's not stressed, and that her babies is also taken care of. All right, so I listed the one in Igbo land, Omugo. On the bottom of this slide, there's similar traditions throughout Nigeria and throughout Africa and other countries. I'm not going to pronounce the Yoruba one because, it's been a long time since I've lived in Nigeria, okay? But if anyone is familiar, they can keep those things in mind. Now, in India, right, they have a tradition where the woman is basically confined at home for 40 days and has specific restrictions. In China, there is something similar, okay? And this is very specifically inside the house, indoors. Again, if you're following it very strictly. So again, and then you see with China, no housework, you're just there. You're supposed to relax, eat, recover. Now, these are all beautiful traditions, okay? But it is also important to see how they might create some stress. Not everyone wants to be indoors in the house for 40 days, okay? Not everybody wants to be with their mother-in-law or their mother for a long period of time, okay? For many of us, mother-in-law, we think we can't necessarily be ourselves. We don't want them to see us, struggling to go to the toilets or with messy hair, things like that. So it can create some stress, even though the intentions are well-meaning. Now, this leads into what can family do? And this is the final part of my presentation. Now, husbands, partners, caregivers, okay? I put husbands first, but not everyone has a husband, okay? So make a postpartum support plan. And that actually includes what I was just talking about. So say your mother, they're all excited, like, okay, we're gonna come for 3 months. Talk about whether you want that to happen, okay? And husband, listen to your wife, and wife, mother, be honest with yourself so you can plan for those things, all right? Husbands and caregivers, come to the appointments, the antenatal appointments and the postnatal appointments when you can. Obviously, if you're working, you can't leave work that's okay. And the reason why is so you can get to know the providers involved in your wife's care in case you need to contact them after the baby is born. Take notice of the symptoms that I was discussing, okay? And just, you don't have to try to fix it, but just try to be reassuring, okay? If when we're talking about self-harm and suicide, you need to address that immediately, okay? So don't say, oh, you don't mean that, you wouldn't do that, or, okay, you feel better. You need to address it immediately. Now, essentially, I'm saying you need to be an active participant, okay? So help out as much as you can at home, okay? So feeding, all right, household chores, okay? And don't wait for her to ask you, because again, there is a big sense of shame with this, all right? It's a little embarrassing when you feel like you're struggling with these things and you need to do them. So try to do it with your own volition without waiting for her to ask you. Same thing with eating. If she's breastfeeding, she hasn't eaten properly in some hours, bring some food over to her so that she can eat, when she finishes. Same thing with nighttime duties. I talked about that a little bit before. And again, be present at those doctor's appointments. Now, for you, this can be stressful as a husband or partner. Try not to take, if your wife is irritable or angry or accusing you of things, try not to take it personally. And just remember, this could be part of her postpartum depression. Now, in terms of, and I mentioned to you before that men are at risk for postpartum depression as well. So keep that in mind. And you yourself, if you notice you're struggling, it's something you might want to talk to. You could actually talk to your wife about it if she's doing better than you are, okay? Now, that's the end of my presentation. And I want to open it up for questions, including things that I've referred to or treatment aspects that I haven't discussed.
Thank you so much, Dr. Katherine. If you could stop sharing your screen so we can see everybody's faces for this discussion. I mean, this was fantastic and this was very real. Just remembering my own experience. I have 2 children. The first delivery, I was so cranky that when it was time for the second delivery, my husband was trying to push the elective CS by 3 days so he could catch up on sleep. First of all, just knowing that I was going to change immediately, it happened. So really eager to hear from questions and comments from the group. If any of our other subject matter experts want to chime in. I think the first question would be, how many of us experienced this? If you could chat in, or if you want to just unmute and speak. How common are we seeing this? To the obstetricians, the family physicians on the call, how common are we seeing this in our clinics? And, to the moms on the call, feel free to share your experience as well. This is a closed group discussion. So do any of the health facilities want to speak up about, are you noticing this, or are you able to even pick this up? How are any of us screening for this in the group, in our facilities? And we have some questions here. We have
I just wanted to mention that, yes,
go ahead,
I do, as a family physician.
Go ahead, Dr. Emua.
Okay, can you hear me?
Yes, we can hear you. Go ahead, please.
As a family physician, yes, we do see this not uncommonly, especially because even a lot of family doctors manage pregnancy. Some don't. They only manage adults and children. But we still have patients come to us, even though they're seeing their OBGYN. If they're having changes in mood, they may not think to see the OBGYN, they may think to see us first. And then even when someone delivers, until they go for their postpartum visit, that's usually maybe 6 weeks away. So anything they have before 6 weeks, they may come to the family doctor. So yes, it is something that is not uncommon. But as Katherine said, you actually have to be aware and look for it. So that the patient is coming, oh, I can't sleep, I have this. One of the questions you want to ask is, okay, just had a baby, XYZ. because if you don't, you'll think of other things. You won't put depression as one of the possibilities. So definitely something we see, but even more so because the person's coming to us and we're thinking, is this a migraine? Is this? We definitely have to have depression in the forefront of our minds before we start thinking, is this blood pressure? Is this? So so yeah. So just wanted to your question of whether this is seen in other um, practices.
Thank you very much, Dr. Moore, for your response. We have a question. At what point is it not considered postpartum depression? And how do
And
we know
that's
what antenatal depression is, given that generally women feel like tired and, low during pregnancy? How do we know that this is really depression while the woman is pregnant? And then at what point do we now not count it as postpartum depression after delivery?
Yeah, so for antenatal, yes, I mean, like tired, low energy, motivation is very common. I mean, really, when you start to get complaints of the mood, okay, so feeling either sad, feeling kind of hopeless, dreading everything, and then sometimes the anxiety. If it's just tiredness, I mean, and I, when I see my patients, because I have patients who I've seen for so many years, right? So fine. Now they're pregnant, and then I start assessing them for the postpartum, for the antenatal depression. So usually, what comes up is feelings of sadness, tearfulness, hopelessness. Not being excited about the upcoming birth, and then not being able to function, and sometimes having suicidal thoughts. Now, in terms of postpartum depression, I mean, I referred to it very briefly, but in terms of the diagnosis, it is controversial. So in United States, we use the DSM-5, okay, which if we go by that book, anything after 1 month, okay, any symptoms that are developing after 1 month are not considered postpartum depression, okay, which I don't agree with, but that is what it states. So if you go by the book, then you're going to miss a lot of people. The ICD-10 says 6 weeks, okay. However, it is known, in fact, I was reading an article about when they were putting together the DSM-5, there was a whole group of individuals in the nursing profession, in midwives, you name it, who were advocating to extend the length of time to include in the criteria. So I would really think about it as up to a year, just on a practice day-to-day basis.
I love the way we went about, incorporating the family, the role of the family, the role of the healthcare workers in this discussion, because that support system is really needed. We have, comments in the chat around, having the fathers attend at least one ANC, incorporating counseling in, towards around this, so the woman is aware and she can recognize it and seek help. So there's a question around if there's more counseling of men and women before delivery, so during the antenatal period, does that have an impact on postpartum depression in both the men and the women, do you think?
Yeah. Wait, actually, let me ask you a question. When they say counseling, do they mean just check-ins and just going over the symptoms, or looking at their risk factors? I'm assuming that's what they're asking about?
So typically, most antenatal clinics would have the health education bits. So we definitely need health education, postpartum depression incorporated into the health education topics that are addressed during the
Absolutely.
general clinics.
Yeah.
But also, and I know the facilities on the call will respond to that. There's also no specific attempt to screen for postpartum depression during the antenatal and at the follow-up visits.
Yeah.
So you sharing these tools is really great, and it's something that we would share links to these tools, like they're basic questions that we can incorporate. Do you think that if we start more education and then counseling on how to address it during the prenatal period, that there will be an impact?
Absolutely, absolutely. And I didn't include these in today's presentation, but there definitely is a lot of research in the United States. I've seen it U.S. And actually India, okay, where when they did antenatal counseling and education, it helped to decrease the risk of postpartum depression afterwards. And in one of the articles, it was also suggested that if you can identify some significant risk factors, okay, so I mentioned a few of them, okay, trauma, for example, okay, that you try to direct the individual to a pathway that might help reduce that risk, or financial issues. Again, I think in the US, there is a little bit, I would say a bit better here, right? So obviously we have everything from adult protective services, child protective services, so that helps to mitigate the risk. But it's really about decreasing the risk beforehand, addressing depression that's occurring beforehand, which will then improve outcomes afterwards.